Good morning. We are ready. You can call the chairpersons and we start the case.
Good morning, sir. We are all here waiting for your case. So we've just finished the case in box by Dr. Sai Satish of a complex mitral clip, and the audience is also here, and the fair number of people. We are waiting to see your very, very complex case. I believe the low coronary heights. So we are looking forward to see what innovation you use.
Good morning, Karan Sitaram, and good morning, chairpersons. I think the first case of the second day, and this case being done in Apollo, Hyderabad. Operator is Dr. Ramesh, and Dr. Manoj Agrawal and Dr. Rufus will introduce the case. This is simultaneous transmission from Medant, Praveen Chandra is doing. So you can alternate. This is a complex case with a small annulus, low coronary, and a really tricky case. I will see how Dr. Ramesh is handling this case. Over to you.
Thank you. So our patient is a 76-year-old female who is a hypertensive, who has a breathlessness which was class 3 and 4 for the last 6 months. She was evaluated and found to have a severe aortic stenosis with a mean gradient of 77 millimeter. On evaluation, her coronaries were normal. Her STS score was 2.2, and ECG shows RBB, and echo shows a mean gradient of 77 and max gradient of 129 with mild AR. The CT evaluation showed aortic annulus area of 303, and area derived annulus is 19.7, and LVOT is similar to the annulus. The sinus of Valsalva is around 24-25 millimeters in the right and non-coronary sinus. Here the main point is the height of the right coronary artery is 10.8 millimeter and the left coronary artery is 7.6. This we are showing you the annulus, LVOT and the SOV diameters. The fourth slide is the coronary height, which is low. Here we are able to see the calcification. The calcification is mostly in the valve leaflets. This is the deployment angle, and we have a good size femorals on the right side. So it is basically a low risk patient with a tricuspid aortic valve with low coronary height and mildly dilated ascending aorta. So she was given the option of surgery, and she was not willing for the same, and hence we are taking her for TAVR.
So Anil, even though this is a low risk for STS, I think it definitely falls into high risk because of the low coronaries and bulky leaflets, and heavy calcium, mean gradient is very high as well.
Another thing we should not forget is RBB, right bundle branch block, pre-existing.
Yeah. So there are many contraindications for actually considering a TAVR option here. You have small annulus, you have low coronary height, not a generous sinus of Valsalva, right bundle branch block. Maybe I could get some inputs from Dr. Jaiswal about how he would approach this.
Why specifically the balloon expandable valve here?
Why?
Yeah, because of the coronary heights and coronary access.
Yeah, it's easier to do a chimney, or it's easier to do a coronary protection with a low height valves, which is balloon expandable valves, compared to a self-expandable valve. And Anil, we must realize if you try to do a deeper implant to protect the coronaries, which comes with a price, we may end up with a pacemaker in a patient who has got pre-existing RBB. Yeah.
Very bulky leaflets.
Yeah, very bulky and calcified leaflets. Dr. Ramesh is trying to enter the LV.
I didn't want to do it until you came on live just to show how difficult it is.
So I see
and
you
I think
not
while
protected the right
trying,
coronary
you can
artery
see
because...
that
Okay, let's show you some pictures in the meantime, and then I'll take a glide wire.
Yeah, glide wire.
Yeah.
Just show the previous.
So let's show the axis picture first.
Yeah.
Okay.
Thermo wire. Next.
So we protected the femoral arterial axis you saw. Now we're protecting the coronary artery on the left side. And then we take next picture. We'll take an iotogram. So as you can see, the venous axis is from the left femoral. There's a pacemaker from the left femoral, and pigtail from the left femoral artery, and EBU30 guide from the right radial, and run-through wire short in the LAD. And here in this view, it looks like that the right coronary height also is low. So how many of you would just say, go ahead and protect the right coronary now, versus whether we should do balloon sizing? So that's the discussion. You can let us know what you feel.
I mean, although on the aortogram it looks like the right coronary height is also low, but you have the CT which says it's a little more than 10. So both choices are okay, but certainly we would be much more confident if the right is also protected.
Okay. I think that's not a bad idea to do that. And in case of, if all of you agree, we are planning to just take the pigtail and exchange it for the right coronary guide. You know. Let's keep that ready.
Right coronary guide. Okay. RC guide 3.5.
So this patient has AI as well, but you can see that bulky leaflets, and it's not easy to cross at all. Right. Yeah.
RC guide 3.5.
Let's. So ACT is 245. We'll repeat another ACT as well. And any suggestions on what do you want to do now? If you can't cross the valve.
2000 heparin.
I mean, obviously, there's nothing like that. You can't cross the valve. People say, you know.
It's just because the valve probably doesn't like the camera, so it'll just cross in a moment.
Yeah. Right. I mean, otherwise, don't feel any ego at all, and hand over to Manoj here. You can.
1 meter time.
Do you have a third wire of choice other than Teflon and the thermo wire?
So there is a question, is there any other wire that you would choose other than Teflon straight or Terumo straight?
No, I changed the guide actually. I mean, the catheter, I go into from AL1 to JR4, and sometimes that actually helps me to cross the especially thick bicuspid leaflets. That has been better than AL1 for me at times. And so that's another one that you can think. And I haven't used usually any other wire other than either Teflon, I mean, Amplatzer AL straight wire or the glide, I mean, not this wire that we're using now.
AL2 we can take.
So Manoj, while you, I'm sure, get your wire across, which you'll do in the next moment or two, we'll just go across and see what Praveen is up to.
Sure, sounds good. Okay. And we'll do that coronary protect the right coronary as well.
Yeah. Okay. Meantime, yeah. So if you can hand over to get across to Gurugram.
Yeah. We can take this out and.
So Adi Yadav here is recommending that you can actually get through to the.
Yeah. Yeah, you are in.
Yeah. So we are already crossed across. Just as you said, you know, we thought we were off the camera.
Yeah. No. We got that. So we've not yet moved to Gurugram.
No, the wire listened, and as soon as it said, "Oh, I'm not on the camera," and it was able to
go transeptal.
Yeah. Okay, so we did a balloon, 18 millimeter balloon inflation with an iotogram to look at actually the coronary filling. And this LAO, the RCA looks at to be much higher than the left system, and the left actually is filling without any problem. So we are now very happy that with this angiogram that coronary occlusion is not going to be that high of a risk. It can still happen, so we need to be prepared. So what we did is we went with the guideliner. Next picture, please. Okay, so the guideliner is introduced into the LAD, and I pulled back the EBU30. So this is where we are, and now we'll go ahead with the valve. As you can see, I showed you that right femoral axis where the large python sheath has been placed.
No, wire, just wire.
Just on the wire. Okay.
Just on the wire.
You can zoom out if you want.
Yeah, you can zoom out. Low magnification.
So we're doing it in under conscious sedation, so a little bit pain while advancing the sheath.
So this is a confida wire?
I mean, advancing the valve through the sheath. This is a extra small Safari.
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 Yeah, we are out.
Okay, we are out, and
Hello? You want me to rotate?
yeah, rotate, and let's go to the deployment angle, please. Okay, more. LAO 10 cranial something,
More
right?
rotation? That should be okay?
Yeah, more. Yeah.
Okay.
Go to 50%.
It's more than 50%.
Yeah. Okay, good. Okay, we had to balloon size not only just for that. As I told you yesterday, I always pre-dilate all severely bulky leaflets, severely calcified, or even gradients which are like more than 60. Here it is 65 mean gradient.
Lovely.
And
yeah.
Okay, we'll take another picture here, right?
Yeah.
That looks good.
Little bit deep, maybe.
A little bit deeper. We want to be a little bit deeper.
That
is what Manoj is saying, telling
okay.
me, which
okay.
I agree with that. And so let's go ahead and take a picture, please. Okay, inject.
Maybe up, no?
Yeah. I think that's good positioning because we want to make sure the left doesn't get obstructed.
Okay.
So, yeah. Are you happy with that, Anil?
Do you think it's a little too deep?
Yeah, I think it's maybe we are trying to be intentionally a little deep.
I know. You're
because,
trying to protect the coronaries.
The coronaries.
It's between the devil and the deep sea.
Yes.
Yeah, we already have a pre-existing RBBB, so.
Yes. So I maybe if you think.
But a pacemaker is
come
lesser
back
of
just
the two
a hair.
evils.
Okay. Lesser of the two evils, right? Okay.
Okay.
So we'll first pace at 180. This will be the valve deployment. Start pacing it, please.
It takes a couple of seconds before.
Yeah, and we'll do a slow inflation. So the pacing is now picked up. Okay, inject. Okay, pigtail is back. Go inflate. Inflate slowly. Go ahead. Go ahead. Commit. Push it. And pull back pacer off.
We can't see the ECG very well.
Okay, good. Can you show the EKG, please?
Just.
We're getting the system out first. Okay.
Okay. Thank you. Let us see.
Okay.
Senior.
Couple of things to look at first, actually.
Yeah.
Let's look at the coronary injection. Okay. Small puff. Okay. So let me pull the guideliner back a little bit and advance the guide.
Wire.
Yeah.
Wire. Yeah.
Okay.
That should be okay.
Okay.
We should be able to. LAO 40.
You can put a pigtail on this?
Yes.
So I'm also trying to be like Praveen and trying to simplify. Let's see if everything is good.
Shall I take an injection? You want some cranial on it?
Yeah, we can put some cranie in. That's too much cranie, probably.
Okay.
Okay, a little less cranie, please.
Less cranial? There is no. It's a plain LAO.
Okay, that's fine, yeah. Wire out. So I'll take a picture just after the showing the hemodynamics first. Flush. Do I have two hemodynamics? Where's the other one?
This one, 1 minute, this one. Yeah, it's there.
Okay.
Yeah.
You can see that the pressure.
I don't know whether. Anil, can you see the
Yeah,
hemodynamics
we can
on
see
your
the
screen?
hemodynamics. Maybe you need to zero both the the transducers. So.
Yeah,
But we still can't see
right.
the EKG.
I'm going to flush you. Oh, you can't see the EKG. Okay. EKG is, let's zero one time, both. This way, right? To zero?
Yeah,
Okay.
yeah, both 0. The pigtail is probably irritating the LV.
Yeah.
Ramesh, people have started pacing through the
Yeah.
LV wire. In this situation, like you have on a coronary wire, is it possible to pace through the coronary wire during implant?
Yes, sir. It is possible. Yes. It is possible. You have to make sure that it is seated well. Your wire is in nice contact. And you can sometimes might have to put even in a small diagonal or septal. Septal is preferable because if there's any perforations, you don't have to worry about it. And then you can pace through that, yes.
Because LV wire
So
can
the
be
way
have
to
a chance
pace
of
is
moving up
take
and
the
down.
black.
LV wire,
Right,
while they
absolutely.
are taking a
So
device, it has a chance of moving up and down. So coronary wire usually stable position. I think that will
Right.
be better.
Yeah. Yeah, Bernie
Yeah, but,
Meyer has done, we can take an angio.
I
He's the
don't
first
think-
one who has done it.
Yeah, I think you're.
Cusp is there, no?
The leaflet is still
Yeah.
there, I think.
Sorry, the leaflet is still there.
Yeah. What do you think, Anil? Should we go ahead and put a stent to prevent from that guide liner? I mean, the guide liner
I think we need
is
another
passing
view
easily.
because I'm not sure because what happens to that leaflet there?
Let's go to
PA clearance,
ariocaudal or something.
ariocaudal.
Ariocaudal.
So yeah, so that's why the question is
I think there is a
whether
leaflet
that
which is
leaflet is obstructing.
yeah, which is probably there, abutting
Yes, yes.
right.
Right, okay. And inject. Now that's because the guide liner is there. I'll take another picture. You know, the guide is, okay, now it is better, okay. Okay. I think it looks good,
This is
right?
quite
Anil?
all right. I mean,
We can,
uh,
yeah. Yeah. It looks
Peter,
good.
any
So
would you
if,
leave this?
just to,
Dr. Andreka? Perfect, he says, and perfect. So anybody else in the house who would like to do
Anil-
something? Because I think we are all quite comfortable.
Anil,
he wants to show the EKG. Can you bring the
Anil, do you think there is a role of IVUS there?
Is there a role of IVUS? We'll put it to debate. Not in our minds, but if there is anybody here who would like to ask for an IVUS, please say your bit. Amit is walking up to the mic. So I guess.
Ramesh, your leaflet is going above the coronaries, if you see. And the leaflet, this flow could just be because your guide liner is over there, keeping the leaflet away, and the flow is there. So I would suggest pull back the guide liner, leave the wire over there, wait for some time, and then take an injection to see.
So they did
if
that.
that is actually
They did that. They did that.
Okay,
The last
that-
shot was
This is-
with the guide liner pulled back.
So go forward one picture.
Go forward. sir.
Yeah, so this picture is without the guide liner, and go back. And there's one picture with and without the guide liner, Amit.
then it looks
So this
perfect.
picture, what you're seeing right now, there's no guide liner.
Then it looks perfect.
And you can see the EKG, move that back. Okay. So EKG is a narrow QRS and a heart rate of 85 with a regular sinus rhythm, you know.
Go back. LAO.
Now there is no staining there. Earlier in the LAO view, there was some staining.
That was the
Here's the coronary
leaflet
angio.
which was
Right.
which was
No,
there.
Can we repeat it and see? Because now it's very clear now. The RIO view looks very clear.
So there is a suggestion that
Very clear.
maybe
You want one more picture?
maybe you could do another injection in an eleocranial view.
Anil, is it a good idea to
Okay.
pull the wire, just keep the soft portion there? Because the hard portion may also be keeping the leaflet little away.
Dr. Clare has suggested you could pull the wire back and see if the leaflet obstructs. But I think if you can just repeat one injection in an eleocranial view, it'll probably make things very clear.
So I had a similar situation where everything was
So,
looking good, pulled the wire,
And
it was still flowing. 15 minutes post that patient had a this thing. Then we rewired and did a chimney. So I think we should wait for 15 minutes if we are not, because the leaflet is almost reaching to the topmost part of the left main. It is very close to the artery. So sometimes it
across the left main. It's not half also.
Yeah.
Partial flow also is okay.
So this is what we did, Doctor. I listened to both of you suggestions. I pulled back the wire to the soft part and in the left main, and then repeated an injection. You can
so
still
in
see
this
that
view,
there
it
is,
does
the
appear
sinus
that the
filling
leaflet
and-
is reaching up to the left main. So
Right.
it would maybe the best thing would be to wait for a little while to see how this goes.
Right, yeah.
Go to PA coordination.
So the hemodynamics part and the valve itself is very good. I'm not worried about that at all.
I think
What
it
I'll
may be
do
a
is
good idea to do
actually
IVUS.
create.
It may be good
No,
idea to do.
even if you do an IVUS, because sometimes the leaflet may be dynamic. Once you have a wire and a guideline or an IVUS catheter in place, it will not
We'll do
abut,
an aortic
it will
root
not
shot.
it will not close the vessel.
Yeah,
But once
certainly
you
it will
come
not
out,
be
it may.
100%
This is what exactly has been.
The leaflet is already on the left main, and just only the upper part of the left main is filling to the lumen. So I think it is best way to
Just
stent it.
LAO, like I mean, yeah.
Cannot
right,
do
right,
without
right.
stenting
With parallax removed.
because it may occlude.
Yeah, that's what.
No,
Even if you do IVUS, yeah, I agree with IVUS might not give us a whole impression because obviously
See, the
we're
IVUS
going with
can
a
only help
guideline
us
or
in
a guide
defining
or
the left
it
main
is-
diameter. Other than that, it's not going to help us.
Right, exactly. Right, okay.
No, it can show
Yeah,
you
we
the leaflets
understand that.
also. Anil,
So if
we
there
must
is a-
remember but we must remember
Ready to
late
inject?
coronary thrombosis also
Inject.
with this leaflet across.
Okay, so
That's
this
true.
is just to show there's no AI.
So we are. I think now the house is divided here. Earlier, everybody was gung ho that the case is over and done.
That's better.
But I think with all this that we have seen, we are open to your putting in a stent in the left main. Amit is coming back.
This injection, if you see, there looks to be something on the left main.
Yeah, it
Yeah.
does look to be in the left main.
Flip.
So we are saying that the
That's there.
leaflet has
Maybe
reached.
if he pulls back the wire,
One more, minus
after
one,
some
yeah.
time everything is going to
Yeah.
get closed.
So we would be
Okay.
with you if you are.
We'll go ahead and
if
put
you're
a
wanting
stent.
to stent the left main.
Yeah,
4 or
that's what.
12?
Just deploy the stent in the left.
We are going to stent right now.
Yeah.
So I think somebody asked earlier why balloon expandable and not. See, look at the size of the aorta. It is slightly aneurysmal in this patient, even though she is a tricuspid valve. Based on the aortic root size, I actually feel the dissections are higher in such patients when you don't have the ability to flex your catheter. So in the future, I think the FX is making it a little bit easier, and maybe those are the things that we can think in the future whether what valve type might make a difference. So for the time being, I chose that balloon expandable in this patient with a small annuli. I agree that small annuli, you might be left with a higher gradient with balloon expandable. And but here we got a great result. Looks like that hemodynamics are okay and no
4/12?
AI. And we'll put a stent right now.
4/12?
Yeah, 4/12. We chose a 4/12.
Hello?
Yeah.
Hello? 30, 40, whatever.
Yeah, this view is okay too.
Okay.
Yeah.
We are in AP.
Okay, whatever that view is.
Okay.
That's it.
You have to give XR and antiplaque.
Yes, sir. Dr. Rath suggested 4 or 12, and so that's what we went with. I'll
So,
get a
Dr.
guideline
Ramesh,
first a little bit in just to make sure
do you
that.
prefer putting the stent later, or do you want to keep the stent in the coronaries in case it is a acute occlusion? And so what is your usual strategy?
No, you're talking about
it's better to
preloading
put
or
now
now
rather
itself?
than
Preloading
keep
the
it.
stent, keeping it in the...
He wants to know when would you like to take a preloaded stent in the coronaries when you're deploying, say, the valve. That could have been done before even the procedure.
Yeah.
That's what you're trying to
Yes.
say. Yeah. When do you preload a stent in the coronaries?
Yeah.
Hello,
I don't preload now because it's I
After the
used to waste
guideliners
a lot
are
of
available.
stents by preloading and yeah, right. After the guideliner is there, I don't stent at all. I mean, don't place the stent ahead of time. Can go in a little bit. Okay, I'm happy with that. Are you guys happy with that place? Oh, it went in a little bit. Okay. Okay, let's take a picture there.
Okay.
It's hanging out into the aortic a little bit. Yeah, that's okay, right? What do you think, Anil?
Yeah, but the only thing is if somebody does a secondary intervention
part.
here, there's going to be a challenge with
Right,
both
yeah,
the stent
that's
and the valve there. But all the same, I think 1 or 2 millimeters outside the left main should be absolutely fine, and we will abut the valve leaflet also.
I take an injection. Right. Yeah, this is the marker is slightly. I mean, the stent is slightly inside the marker, and I think that looks actually very good.
Which stent is this?
Okay, I'll go in a little. What stent? Zions is the one that we chose.
Zions is on the
Okay,
mark.
go ahead and. Okay, that's good. Okay, yeah, on the marker, right.
Yeah.
Okay, inflate, yeah, it went in. It went inside. Okay, down. It went inside it.
What is the size of this
4012,
stent,
yeah. 4012, sir. 4012 Zions. So balloon again.
Okay, then we maybe use a 5
Inflate.
balloon to dilate.
Yeah. Okay, down. I was just inflating with the same balloon a little bit to make sure that we are okay. Okay, I just want you to inflate one more time.
It's going in, sir.
Yeah, pull back and.
No, your guide is, I think, pushing it back.
Okay. Guide, I pull back the guide.
Yeah.
In deflate, right?
Yeah.
Okay, 1 minute, hold on.
Manoj,
Okay,
it will
go
be
ahead.
interesting to do an IVUS or an OCT now.
Yeah. Okay. Deflate.
But Japanese have done a study with these kind of patients, and they found it's useful. IVUS will tell us whether it's obstructing the leaflet is obstructing the left main ostium or not.
If you see, while you were inflating the stent just jumped in. Could it be because while you were inflating, the leaflet just pushed it inside?
So I think that was something we also noticed, but it was probably a dynamic play because.
Sorry, I thought you were injecting.
No, sorry.
Yeah. I don't know whether the stent actually is inside too much into the left main, I think. We'll get a quick IVUS in, as you are saying anyway. So, is it not quick or is it?
No, it takes time.
It takes time. Okay.
By the time the setup.
So I think we stented the left main, but I don't think that the left main is coming out into the annular area. Unfortunately, it moved forward a little bit. So, yeah, what do you think? Dr. Rath is saying, should we put one more?
Yeah.
Right. Yeah, give us a short 4, 5, 8 or something, please.
4.58.
If you're taking another stent, yeah, make sure it's either 4.5 or 5. See now.
Fluoro, save that and play that, please. Play it. Yeah. Yeah, sorry, Anil.
Freeze.
It's definitely moved by like 4 millimeters inside, almost.
Probably the guide was there just because of
Yeah, I'll think initial my thought was just to make sure the marker touches the frame of the mirror,
valve
my
frame,
valve, and deflate it that time, and that's what we'll do. It's my mistake that I thought, okay, let's position it precisely, and it did not work. Okay, if not 45508.
50 would be best.
Yeah, they're looking 508, if preferable, if not 458.
9 also is okay.
Yeah, 9 also is okay. You have 6 millimeters, right?
No, no.
Only balloons, right?
Nobody uses it, so.
Yeah. 512, sir. Okay.
It should be
right. Yeah, 512 is fine. Yes, yeah.
Hmm?
We have 512 is the next size that we have. Onyx, we are going to take that. I don't want anybody to comment on about the interaction between Zotorolimus and Everolimus now, please.
No, they're both limus, so it's okay.
Okay.
You don't need an injection for
I think that looks good. Okay.
Yeah.
Go slowly. Okay. Yeah. Yeah. Okay.
Would you like to check in a cranial view?
It's going in again. Huh.
We're already deployed.
We are a little bit. Yeah. Can you?
Little bit cranial.
Little bit cranial. With
cranial sinus.
Okay. Go ahead and inflate it.
Huh. Okay.
Okay. 12 and then down.
We'll bring it back and then.
Okay.
Now.
1 minute, hold on. Okay. Go ahead, inflate. Okay, that's good. Down. We didn't do the overlap. Okay, go ahead and inflate. Inflate 12 again. We're just doing the overlap. And okay, down. Yeah. Okay. Ready to see?
Yeah. You have to take out.
Why are you having difficulty because of the balloon?
And
so let's we'll take a better picture one time. Just let's. No, and the big 5-0 balloon is sitting in the guide. And sorry. Okay. Okay, Flora. All right. Okay, we'll take one picture in this view and one in area caudal. Ready?
Yeah.
Okay. I think it looks the same. I don't know whether that's a area caudal, please. And I think I'll be okay if now taking it out and waiting for 15 minutes. We are in the room. We'll go offline and then we'll let you know what happened to the patient afterwards. Okay. Yeah, I'm happy with this. Okay. Yeah, looking at this, I mean, we stented it just to be on the safer side.
Would you like to take a cranial view just to be sure that the ostium is clear?
In which view? Eleo-cranial, we did that.
Cranial,
that's the eleo-cranial.
Maybe okay. Cranial 30, 40.
Yeah, can you go to epicranial 40? Okay.
The leaflet still is not pushed down. It looks like it is still there.
No, it's not a dissection. There's no dissection. That's just, I think, it's filling the sinuses, in my opinion. But we'll wait here and see if we need to do anything further. I don't think that.
Okay, okay. I think it's still a great job done. And, our minds have been open to all the possibilities and the step-by-step approach to handling low coronary ostial height in a small annulus, why you chose balloon expandable stent valve. So I think with this, Dr. Sitaram is moving on to the next program, and we thank you for a great case, and thank all the audience who've been here since 8 a.m., and thank all the co-moderators. Thank you, Ramesh. Thank you, Manoj. Thank you, Dr. Rath.
Thank you.
Bye-bye.
Thanks to the audience and Dr. Rath and Dr. Manoj. Thank you.
Great job.
Thank you.